Thank you to the organizers for inviting me to give this talk. Following the revolution of combination antiretroviral therapy, we all, as clinicians and scientists, I think are faced with a major question, which is whether or not we're in fact fully recovering the health of our cART-treated patients. And studies from large cohorts, like for example the ART cohort collaboration with over 80,000 persons a year, are indeed reassuring us that this is what is happening. And in fact, the life expectancy of patients has increased substantially in the past few years. And yet we still see that even after long-term HART, our patients develop severe non-AIDS diseases. And so this brings to the notion and to the hypothesis that the pro-inflammatory status that characterizes HIV since the very first phases of disease might in fact impact and be one of the causes of the excess morbidity and mortality in the cART era. Indeed, it's been back in the beginning of 1990 where Janice Georgi demonstrated in HIV untreated patients an excess in activated T-cells that was in fact associated independently to the loss of CD4 and even most importantly to clinical outcome. And it was clear from the beginning that a strong association exists between T-cell activation and viral replication. So once we resolve viral replication and once viral RNA goes to very low level, we expect to find a decrease in T-cell activation. And indeed, this is what happens, even though very many data have now come to the conclusion that immune activation, T-cell activation, but also activation and inflammation really remains even after long-term HART at levels that are higher as compared to HIV-negative individuals. And most importantly, and I'm just a little bit anticipating what Peter Hunt will talk about, this seems to be in fact predictive and associated to important clinical non-AIDS related outcome. So this brings to the scientific question which is out there, which is what are the drivers of such persistent residual immune activation in the context of cART? And this is a checklist that I'm sure it's not 100% complete, and this is all what I'm trying to go through with you in the next 15 minutes or so. I will start off by talking about gut and the damage of gut, because we know that gut is a major site of HIV pathogenesis, and we also know that the major changes in the gut that happens in the course of HIV are not fully reversed by therapy. In fact, when we analyze the CD4 counts in the gut mucosa of even of patients that were treated in acute infection, we see that there is an important depletion higher than what we see in peripheral blood. We also see that upon cART there is a reduction in both the transcription and the protein synthesis of the tight junctions in the colon, and that this data associates not only to microbial translocation, but also, and I think this is the most important data, it does associate with immune activation. These are data by our group and also others that have shown these associations between low tight junctions levels and immune activation. In the course of HIV, both in animals and in humans, it has also been described an alteration, an important alteration of the gut composition of the gut microbiome, which is not reversed by HART. And again, this is a data set from our lab, where we analyzed the feces and the microbes in the feces of 50 patients, both before and after therapy. And what we saw here is that at 12 months of therapy, there is in fact a rise in the content of the beneficial lactobacilli, but as you can see, there is also a rise in the Enterobacteriaceae. And so at the end, the relationship and the ratio between lacto and Enterobacteriaceae remains substantially normal. But does this impact, immune activation? The answer seems to be yes, and in fact these are data by Ellis in JADES 2011, where there was a nice correlation between the proportion of inflammation-thriving bacteria and the generalized T-cell immune activation. Then we do have an excess of microbial translocation that persists despite virologically suppressive HART, and that has been shown to also associate to the recovery of CD4 cells under cART. But the major questions in the past few years has been what are the causes causal nexus. Is immune activation that causes microbial translocation, or is it the other way around, because both biological mechanisms are in fact very plausible. So it was initially described elegantly by Jake Estes in plus pathogens are co-localizations in the gut mucosa of LPS, E. coli, and immune activation. And several data in humans have shown positive and significant correlations between markers of immune activations and marker of microbial translocations. If you then administer LPS to the animals, you will see an increase in immune activation. And if you expose to bacterial products monocytes, they will increase the proportion of the expression of thromboplastin, which is a major constituent of the coagulation cascade. And this is very much true not only in untreated, but also in virologically suppressed ART. Again, in our hands, we treated peripheral blood monocyte-derived macrophages with LPS, and we were able to demonstrate a rise in the supernatant concentrations of pro-inflammatory cytokines such as IL-6 and TNF, especially in cART-treated, that we did not see or we saw at lower levels in untreated patients. And following up on data by Michael Lederman, who in HIV-negative patients demonstrated that bacterial challenge was also associated to the upregulation of T-cell activation markers. We repeated these experiments in our cART-treated patients, and I have to say we did not see this effect, and our interpretation is that this might be due to a tolerogenic effect given the high level of LPS that these patients have in peripheral blood. If you antagonize in vivo LPS and give sevelamer to the animal, you have a reduction in LPS, but most importantly, you also have a reduction in immune activation. And this data was not replicated in humans, but the cohort here was untreated individuals, opening up the possibility that maybe following ART, the situation can be different. But aside from microbial translocation, another possible gut-mediated driver of immune activation might be an alteration of the immunoregulatory T-cells in the gut. And indeed, we measured in our cohort the proportion of gut-homing CCR9 beta-7 cells, and we saw the following how there was a reduction of this population in peripheral blood, hoping that it might mean a reconstitution of the same population in the gut. But Maud Mavigné had already shown that, in fact, such population was impoverished in the gut as compared to HIV-negative patients, and also correlated with microbial translocation and immune activation. Along the same line, Th17 cells, which are shown to increase in peripheral blood during therapy, but nonetheless they seem to be unfunctional in terms of cytokine production. And very elegantly, David Farber demonstrated in the green patients, which are the suppressed patients, that there is a persisting low level in the ratio between Th17 and T regulatory cells, which in fact correlates very well with immune activation. What about co-infections? There have been great interest in herpes virus co-infections. These are data from ICONA cohort in more than 6,000 patients, 12% of which were cART-treated. CMV co-infection was indeed independently associated to higher risk of known AIDS disease. Why is this? From an immunological point of view, Stephen Dix demonstrated that cART-treated patients have a high proportion of T cells that are specific for CMV, and Sarah Janella in the past years was able to demonstrate in CMV genital shedders an increase in T cell activation and T cell exhaustion in peripheral blood. And again, within ICONA cohort, we also demonstrated an increase in circulating pro-inflammatory markers. A proof of concept that CMV is really relevant comes from data by Peter Hunt, who treated such of these patients. We have to say that not all of these were on cART, but anyway, treatment with valganciclovir resulted in a reduction in T-cell activation, which was not seen lately with treatment with valganciclovir, suggesting that the effect might be very specific on CMV and not other herpes viruses, or at least not simplex viruses. What about co-infection with viral hepatitis? Again, co-infected patients are indeed at increased risk of disease progression, and in ICONA cohort, we demonstrated that in antiretroviral naive patients, co-infection is associated with increased LPS and increased pro-inflammatory cytokines. And this seems to be true also in other cohorts in the context of CART-treated patients. Indeed, this is a nice and recent study of more than 300 patients where co-infected individuals clearly demonstrated not to recover fully the CD4 and CD8 ratio as compared to HIV monoinfected individuals. So in different studies, I think this is very important to show that during CR treatment, being HCV co-infected is in fact an independent factor of having high level of immune activation. And in fact, what happens if we treat HCV co-infection? We do have a reduction in T-cell activation. These are data in 300 patients or so that were treated with interferon alpha riba. And I have to say that this data was not confirmed by other data sets, so it will be very interesting to see what's going to happen in co-infected patients undergoing directly acting agents for HCV treatment. Let's move on to residual replication, because HIV residual replication, because we know that almost all the patients on cART have a persistent low-level replication, which seems, however, not to correlate with residual immune activation. And these data are really consistent throughout the literature, as if the positive correlation that we describe between viral load and replication at high levels of viral replication is somehow lost when we go down to lower level, let's say, for example, below 400, like in this data by a group at Chelsea and Westminster in London. However, immune activation do correlate with residual viremia in specific patients, the immunological non-responders, suggesting that in these patients, this might be a pathogenic mechanism. And immune activation also correlates with measure of residual replication when it is cell-associated, so HIV RNA and HIV DNA cell-associated, both in peripheral blood and in the tissues, to suggest somehow that it is the residual level replication that we do not capture in peripheral blood that somehow contributes to residual immune activation in peripheral blood. What happens if we intensify therapy? Does residual immune activation go down? These are data with Maraviroc that showed an initial reduction in T-cell activation at the earlier follow-up, but however, when we go to a 48-week follow-up, this effect is lost, and these data were reproduced in other data set by Peter Hunt and our own group. What about integrase inhibitor intensification? No difference in immune activation by data by Hiroyo Atano in both peripheral blood and the gut, while different data set in Spanish studies who actually succeeded in demonstrating a reduction in T-cell activation following raltegravir intensification. Is there any possibility that different drug classes impact in a different way residual immune activation? There are studies that are coming out in very small cohorts nowadays that are trying to address this question, but I think that both with T-cell markers and soluble markers of inflammation, there seems to be not a definitive answer. I just wanted to share with you data on 300 HIV-treated patients in our cohort at São Paulo Hospital, where we try to compare the reduction in T-cell activation in patients under PI and on RTI and integrase inhibitors, and there seems to be no effect driven by drug class. Just few words to remember to you all that even under cART, we still have an impairment in the clonogenic capability of the bone marrow and a non-complete recovery of thymic output to further add to the immune dysregulation that we have in the course of HIV. And I will end up by talking briefly about lymphoid fibrosis that, as we know, is one of the major mechanisms driven by inflammation and that drives itself inflammation in untreated HIV and seems to remain also in the course of CR treatment. This is very elegant data, I think, from the group of from Ming Zhang and plus pathogens, where you can easily see that following heart, you do have a recovery of follicular reticular cells that are green here as colored by Desmond, and a reduction in collagen, which is red here. But the effect is very much linked to the stage of disease where we start therapy. So the earlier the therapy, the better the green, and the lower the red. And it's the other way around when we start therapy during AIDS, for example. And even most importantly, the content of collagen antigen in lymphoid tissues, but also in lymphoid tissues associated to mucosa, like the gut, is negatively correlated to the recovery of CD4 and positively correlated to the apoptosis of naive T cells, possibly due to the lack of access to interleukin 7. But is tissue fibrosis an actual driver of inflammation on cART, and how does it do that? I want to end up by mentioning a very recent data by David Asmuth in AIDS, which analyzed a population of cells, myofibroblasts, that were studied in the duodenal mucosa of HIV patients both before and after therapy. And what they demonstrated, these are non-professional antigen-presenting cells that have been described to have a role as both pro- and anti-inflammatory mediators through pathways that are not known 100%. But what is most interesting in their data is that when they isolated these myofibroblasts from the patients and cultured them in the presence of LPS, there is a substantial increase in pro-inflammatory and pro-fibrotic mediators, so linking lymphoid tissue fibrosis to inflammation. I'll end up with a cartoon from a very nice review, which really summarizes the concept that the residual immune activation in cART exists and is indeed multifactorial. And my personal feeling is that we do have to study the specific mechanism, the contribution of the specific mechanisms in different groups of patients in order to really address with therapy the right patient with the right approach. And I want to end by thanking all the clinical and the scientists that work with me at the Clinic of Infectious Diseases of the University of Milan and San Paolo Hospital under the lead of Antonella d'Arminio Monforte, and surely the Icona Foundation for great intellectual contribution, and all the funders. Thank you.
Thank you. Thank you very much, Julia, for a fantastic overview. And what I forgot to mention is that we decided that we'd rather